Welcome to the first lecture of Medidactics. Today's lecture is on the minimal change disease in adults. Minimal change disease causes nephrotic syndrome. Usual manifestations are nephrotic range proteinuria, edema, infections, hypoalbuminemia, and hypercholesterolemia. In this slide, we discuss about some whys of minimal change disease. Edema is caused by the nephrotic range proteinuria that causes urinary protein loss of more than 3 grams per 24 hours. Loss of albumin in urine causes low oncotic pressure and subsequent third spacing of fluid. Hypercholesterolemia is caused by alteration in lipoprotein lipase and PCSK9 activity. Infections are mostly due to skin breakdown and fluid accumulation. In pediatric population, fluid accumulates in the peritoneum that can sometimes complicate into a bacterial peritonitis. Hypercoagulability is due to loss of antithrombin 3, protein C, and protein S in the urine. In nephrotic syndrome, we retain all the larger molecules like fibrinogen, and that can give rise to hypercoagulability as well. Usual evaluation with urinalysis shows microscopic hematuria in 10 to 30% patients and oval fat bodies and waxy cast. Biopsy in light microscopy shows us normal findings. But with electron microscopy, we see podocyte effacement. The diagnosis of minimal change disease in children is made clinically, and biopsy is only indicated for refractory, resistant, or if we are suspecting an alternate diagnosis. Whereas in adults, there are other important causes of nephrotic syndrome. So to rule out those conditions, we need to go with biopsy. The time-tested therapy for minimal change disease is corticosteroids. The adult dose is oral prednisone 1 mg per kg per day, maximum 80 mg per dose. Alternatively, we can use oral prednisone 2 mg per kg per alternate day, 120 mg maximum dose. Observe for 24 weeks in adults before designating as steroid responsive or refractory. Complications of oral steroids for very long term are cataracts and osteoporosis. Infrequent relapsers are typically treated with intermittent corticosteroids. Frequent relapsers are those patients who have 2 or more relapses in a 6-month period, and they require intermittent corticosteroids as well. Frequent relapsing or steroid-dependent patients are those who relapse on alternate day steroid treatment or within 2 weeks of stopping corticosteroids. For treatment of frequent relapsers or steroid-dependent minimal change disease, we can use second-line options like cyclophosphamide or chlorambucil. These alkylating agents are preferred over antimetabolites like mycophenolate mofetil. Cyclosporin tacrolimus calcineurin inhibitors are also another options. Newer studies are showing the effectiveness of anti-CD20 antibodies, rituximab. For cyclophosphamide, we have to use it for 8 to 12 weeks. The common side effects of cyclophosphamide are gonadal atrophy, hemorrhagic cystitis. For mycophenolate mofetil, it can cause bone marrow suppression. For cyclosporin tacrolimus, it can cause nephrotoxicity and it can cause gingival hyperplasia. For supportive care, we can use loop or thiazide diuretics. We can use them orally, or if needed, we have to use it intravenously. Salt is usually restricted to 2 grams per day. Pneumococcal vaccination is also required for patients with minimal change disease or any nephrotic syndrome. Usually, pneumococcal vaccine is administered 2 weeks after the steroid therapy to induce the best response. For conclusion, we are going to discuss on 4 things. ACTH. It was previously used for minimal change disease and is now being reintroduced for treatment of minimal change disease. But we need better data to support ACTH for the treatment of minimal change disease. And we also need better therapeutic options over steroids and all the second line options because of the side effect profiles. Usually, minimal change disease has a good prognosis in children, but for adults, the prognosis can